All right. Next up, we have a presentation on understanding your lab tests and imaging results. This is definitely something that I think all of us that have been on this journey have had to learn almost, unfortunately, by trial and error. So here's an opportunity to learn about it in a very wow, I'm just thrilled that this is a presentation for all of you that are joining us here today. And this is a presentation here from Dr. Kevin Byram, the co-director of the Vasculitis Center at the Division of Rheumatology and Immunology at Vanderbilt University Medical Center in Nashville, Tennessee. As a medical resident at Vanderbilt University Medical Center, Dr. Byram received the Rheumatology Research Foundation Medical and Pediatric Resident Research Award from the Rheumatology Research Foundation. Dr. Byram completed his rheumatology fellowship at Vanderbilt, where he served on the American College of Rheumatology's Fellows in Training Subcommittee and Annual Meeting Planning Committee. Dr. Byram has clinical and research interests in vasculitis and related diseases, and completed a vasculitis fellowship at the Cleveland Clinic Center for Vasculitis Care and Research, which was funded by the Vasculitis Foundation and Vasculitis Clinical Research Consortium. He returned to establish the Vanderbilt Vasculitis Clinic with the mission of optimizing care for patients with vasculitis. Dr. Byram's research interests include identifying unique microRNA expression patterns in patients with ANCA-associated vasculitis, as well as leveraging the electronic health record to systemically study outcomes in patients with vasculitis. So, Dr. Byram, welcome. Thank you very much for attending here.
Thank you for that introduction, Sarah. And Joyce, thank you for having me here. That was an awesome topic and talk by Dr. Godwin. Today, we'll of course be talking about lab results and imaging results. You know, this is a topic that we could sit here and talk for hours about. This is a conference that is aimed at the newly diagnosed patient. So I really am going to start at the ground floor here. This might sound basic to some of you, and to some of you, I hope you learn a lot from it. So, and I'd love to take questions at the end, so we will leave some time for that. We're going to talk a little bit at first about why labs are done in the first place. I think that's a really important thing to wrap your head around, because different labs serve different purposes. We're also going to talk in a little bit of detail about common blood, urine, and imaging tests that are done, and I will try to relate those to the different vasculitis diseases. It's also worth pointing out that, you know, we talk about vasculitis, but it's really, you know, tens, if not more than that. It's many different types of diseases, and so different tests are done in different diseases. And then at the end, we are going to talk about how you can talk with your providers about the lab results. It'll be somewhat of a general approach, but I think that it dovetails really nicely with Dr. Godwin's talk just now about formulating your a really good team to participate in your care. So going over the purposes of labs, I mean, I've listed 5 here, but there are countless others. These are the ones that come to mind when I think about ordering labs for my patients. On the front end, we're ordering labs to help make a diagnosis. But after the diagnosis is made, we do labs to screen for organ damage, and we also will very frequently do labs to make sure that medications are safe to take. There are some screening tests that need to be done before certain medications are used. We also do labs to screen for the response to therapy. You know, is the medication regimen you're on working? And then lastly, I think almost most importantly, is to make sure we're not hurting people with the treatments that we're using. So we're looking for side effects of therapy. And that's a very common reason that someone gets labs, you know, every month or every couple of months as your disease course progresses. There could, again, be many slides based on this topic, but there are certain caveats when we start talking about labs or imaging tests for that matter. There is no test that is perfect, and that's a really important thing to understand. It might be that if a lab result comes back abnormal and it was really unexpected, that it bears repeating to make sure it wasn't a lab or a collection error or a reporting error for that matter. Some labs are more important than others. I'm going to use the example of the complete blood counts in a minute, but in today's world, when the patient has rightly access to their labs through the patient portal or through some other mechanism, it can be overwhelming to see a whole report and abnormal ranges. And so it's just, I'm going to help highlight today the ones that I think most providers are looking at. But it always bears kind of clarification with your provider if a lab result is important or not. It's also worth noting that normal ranges don't always take into account personalized aspects of medicine like age, sex or gender, or body size. And so it might be that a lab value just outside the normal range is actually acceptable for you personally. But again, that bears confirming with your provider. I'm not going to talk about all the labs in the world today. I'm going to talk about, I think, the most common ones that are used and the most important ones. There might be additional ones that we don't touch on today that your provider might be using. And then lastly, in diagnosing vasculitis, there are a lot of mimics. Vasculitis is a rare disease, but there are other things that need to be evaluated for, like infection or other autoimmune diseases. And we're not going to really go into those today. We're not going to talk about lupus-specific labs, for example. It's a little bit out of the scope of what I've been asked to do today, but just maintain a good line of communication with your provider in evaluating those labs. All right, we're going to jump into it here. I have made the decision to kind of forego talking a bunch of numbers right now. I think the numbers can start to get overwhelming, and I think it's more important for the newly diagnosed patient to understand the concept of these labs more than the normal range is between 10 and 14 or whatever. So I think first, let's talk about the complete blood count. As providers, we're looking mainly at three kind of cell lines. The first is the red blood cells, which are on the lab value, on the lab report, you'll see listed as hemoglobin and hematocrit. It's two separate labs. If this number goes low, that's what we call anemia, and that means your blood counts are low. The other two that we're looking at are platelets, which help you clot, and white blood cells, which help you fight infection. Generally speaking, we're worried about highs or lows in any of these, but low counts, I think, are more worrisome just in general. As after you've made the diagnosis and once you get put on medications, many of the medicines we use can affect the bone marrow, which is where all of these cells are made. And if it affects that, then these cell counts can go down. And so your provider is regularly looking at these to make sure that you don't have low blood counts. Now, of course, active vasculitis or active inflammation can cause an anemia in several different ways. And so that's another reason this lab is done. I think another thing that bears mentioning is an elevated or high white blood cell count. This can mean a couple of different things. Many times in vasculitis, patients are put on steroids, and those steroids are known to elevate the white blood cell count in and of themselves. But maybe most importantly, an elevated white blood cell count can herald an infection. And so the first kind of line of questioning that your provider should be asking after discovering an elevated white blood cell count is, do you have any infectious symptoms? So hopefully that will empower you as you see your labs to be also thinking, do I have any infectious symptoms that I need to share with my provider? The next common lab that's done is what's called a basic metabolic panel, or a BMP. By the way, there's a lot of alphabet soup in this. And this is a panel looking at electrolytes. So your nephrologist will be very interested in your potassium and chloride and things like that. But I think the most important lab in this particular panel is the kidney function. Many of the medications that we use are processed or eliminated by the kidney, and so it's important to have a grasp on that. But diseases like granulomatosis with polyangiitis, or GPA, can affect the kidneys, of course. And so this is a very important lab to follow over time to make sure that it's improving with therapy, or to make sure it's not worsening from active vasculitis. This can get confusing, though. There's two main ones that we use. Your provider will have a preference. I, for example, like to reference the kidney function in terms of the creatinine. You'll see it on some labs as CR. And an elevated creatinine is worrisome that there is some kidney damage. There is a sister lab to it called the glomerular filtration rate, GFR, and a lower GFR is worrisome. So they kind of move in opposite directions. And again, your provider will have one that they look at. I was just taught and habit has formed to think about the creatinine, but they both reference the same thing. The next, well, so I think the last very common lab that's done is what's called the hepatic function panel. Hepatic means liver. So these are liver function tests, or LFTs. There are two main ones we look at, the AST and ALT. Those are abbreviations for long protein names, but enzyme names. These are sometimes depending on the lab, they will be called SGOT or SGPT, but high numbers here are worrisome. Many medications like Imuran or azathioprine or methotrexate are processed by the liver and if at toxic levels, can elevate these liver enzyme tests. There are other medications that can do it as well, and another substance that can do this is alcohol. So this is one reason that after if you have elevated liver enzyme test, your provider will likely ask you if you're drinking alcohol. Don't take offense to that. They're just gaining information to make sure that that's not contributing here. It's an important thing to take off the list. Many times that basic metabolic panel and the liver function test will be ordered together in what's called the comprehensive metabolic panel, or CMP. That's actually the more common way to get all of that information. So that's just so you know. Going back to the kidney function, there's three main tests when we are thinking about kidney function in terms of the basic urinalysis, or UA. There's what I call the chemical dipstick, there's microscopy, and then of course there's culture. The dipstick is a screening test whereby it literally it's a little plastic stick that has a bunch of little chemical stamps on it that they dip into the urine, and it's put into a machine, but it can be done manually as well to look and see if there's presence of different chemicals in that urine. I think on the front end, the doctors are looking for protein and blood, which might suggest active vasculitis in the kidney in those diseases like MPA, GPA, and some others, cryoglobulonemic vasculitis. But there are chemicals on there as well that can suggest infection. And so and those are called nitrite and leukocyte esterase. If those chemicals are present, then many times the lab will reflexively order a culture, but sometimes the physician themselves have to separately order a culture of that urine to see if there's an active infection. If there is blood found to be on the dipstick, then the next test that needs to be done is either the provider or the lab technician looks at that urine under a microscope, and that's what we call urine microscopy. And they are looking for things like this in the picture here. This is a beautiful red cell cast. Beautiful in that we can see it. It does mean that there is damage and active vasculitis in the kidney, though. I also think this is the other way to find active vasculitis in the kidney and confirm it would be a kidney biopsy, which is far more invasive. And but still is important on the front end to differentiate it from other diseases like lupus or the different types of vasculitis. So, but the urine can be a very powerful way to very quickly see if there's active vasculitis in the kidney. It is important to know that sometimes the red cells, not the big cast, but the red cells, the individual cells that you see can persist even after appropriate treatment. And so it's up to you, your providers and you to determine if that's active vasculitis or just damage from previous vasculitis. Inflammatory markers, you'll hear that phrase a lot. These are very common tests that are ordered in the context of a new diagnosis of vasculitis and ongoing care of patients with vasculitis. There are two main ones we look at, one called the erythrocyte sedimentation rate. That erythrocyte means red cell. That's kind of known as the ESR, or the SED rate. And then there is a protein called C-reactive protein, or CRP, that we look at. These are very different tests, but both can suggest inflammation if they're elevated. ESR, the erythrocyte sedimentation rate, is a classic test that as patients get older, we allow a little bit higher one for a normal range. And then the C-reactive protein, each lab is a little bit different with respect to the range there. So it's just important to kind of look at the ranges and be familiar with those. But these are both labs that can help screen for inflammation. It's very likely that most of you that were initially diagnosed with vasculitis had some of these done before you were diagnosed, and they were probably quite high. Undoubtedly at that time, it was the active vasculitis that was causing the issue. But it's very important to understand that there are many causes of inflammation beyond active vasculitis. And so once you get diagnosed with vasculitis and get put on immunosuppressive treatment, prednisone included, anytime we see an elevated sedimentation rate or CRP after that point, we have to think about and rule out and evaluate for infection. There are other things that can cause inflammation as well, kind of at a lower to medium level, and things like obesity can do that. So sometimes the weight gain from the treatment, the steroids, can sometimes also cloud the picture a little bit. So I just bring up these things to say that these are tests that can raise a suspicion or a suggestion of an issue, but really more evaluation needs to be done after they're elevated to figure out exactly what is causing that inflammation. We'll talk about a few vasculitis-specific labs. You know, these are very complex labs that are done, but I have some comments on these, and hopefully there's a lot to learn about these. So the first is what's called the anti-neutrophil cytoplasmic antibodies. These are called ANCA, and of course these are associated with the ANCA vasculitis diseases like GPA, MPA, and EGPA, or Church-Strauss syndrome. On the next slide, we'll go into a little bit more detail on ANCA, but there are two essentially subtests of ANCA, the proteinase 3 antibody and the myeloperoxidase antibody. We call these by their short names, PR3 and MPO. Sometimes these tests are definitely helpful on the front end to help confirm a diagnosis or raise suspicion for a diagnosis of these vasculitis diseases. But many times providers will use them over the long term to help follow the response to therapy. That's a little bit controversial, and no decision should be made just on the level of the proteinase 3 or MPO or ANCA, but in the context of the symptoms you're having and some of the other lab results can suggest and can help monitor the disease. The other, kind of briefly, we'll talk about cryoglobulin. It was brought up as a question, so I know there's at least one patient with vasculitis that's watching. But it's a really interesting protein. It's a very finicky test, and this is one of those tests that I think most vasculitis centers are expert in doing, and sometimes local labs have trouble with. This is the blood has to be kept at a certain temperature and incubated at a certain temperature. It has to be monitored every day for about a week in the lab. And what they're looking for is whether or not this cryoglobulin, which is a protein that comes out in the cold, comes out, and then if they do find it, they can do special testing to tell you what kind of protein that is. But this is one test that can be watched over time too. The level of that cryoglobulin can tell us if the patient is responding to the therapy or not. Let's talk about ANCAs a little bit more. This is still a rare disease, but I know are many patients with GPA and MPA and Church-Strauss that are tuned in here. There are kind of two main tests when we talk about ANCA. One is called immunofluorescence. We can call it IF if we want to. And that is a human test functionally. There's a special processing that's done to the sample, and it's a human looking at it under a microscope. There's two things that the human will tell us. Is it abnormal? Does it light up? And then what kind of pattern is it? There are a couple of different types of patterns which associate with different diseases. We won't get into that too much right now, but here's a really good example of what these look like under the microscope. Most places there's two ways that it's done. At Vanderbilt, we send both of these all the time. In some places, they do the immunofluorescence, and if it's abnormal, then they send the second test. But it's called an ELISA test. And I call this a chemical test of sorts when I'm explaining it to patients, because there's not much human to it. Many times this is a sample loaded into a machine with certain reagents, and it's looking to see if it reacts to the presence of antibodies to PR3 or NPO. There's different technologies here, which we won't really get into, but both of these together can really be powerful in helping make these diagnoses. Let's switch gears a little bit to talk about imaging. This, again, is a whole topic in and of itself, but just to familiarize yourself with the different imaging tests that are done. Many times in these small vessel vasculitis diseases like GPA or MPA, we're very interested in what's going on in the lungs and in the chest. So a chest X-ray is a very quick test. It's a fairly cheap test compared to this other test we'll talk about. It does provide a little bit less detail, but it is less radiation. And usually it will either be one view or two views to give us some dimensionality to the image itself. But what we're looking for there is either nodules or, in some more unfortunate cases, things like blood in the chest in these diseases. It also might be used if you have, we'll talk about tuberculosis testing in a minute, but if you have an abnormal tuberculosis test, then a chest X-ray is usually the next test that's done to make sure that there's no tuberculosis hiding out there. If the chest X-ray is abnormal, it's very common for the next step to be a chest CT, that stands for computed tomography. It functionally is a bunch of different X-rays that are put together for a more three-dimensional picture. It does have more radiation. It's about 70 times more radiation than a single chest X-ray, but it provides a great amount of detail. And in terms of the lung tissue itself, the bones, the soft tissue, and this covering around the lungs. So these can be very powerful tests to help us see if there's issues going on in the lungs of patients. And I would love for somebody to ask some specific questions about this. It's a big topic, but the next topic we'll move to is imaging that we use in large vessel vasculitis. I've thusly neglected those with giant cell arteritis or Takayasu's arteritis, but imaging is a very powerful way, an important way we monitor these patients over the long term. And of course, they're super important in helping make these diagnoses. I have a whole 1-hour talk just on this topic. And so, to put it into just a few minutes here, I think it leaves a lot to be talked about, but let's talk about the types of vessel imaging we use. There is a test called a CTA. There's a test called an MRA. The A stands for angiography, which means simply picture of vessels. So one is using CT technology, which has radiation, and the other is the MRA, which uses magnets. That's what the M stands for, and there's no radiation there. And they can give us there's different characteristics. Different radiologists and different centers will have varying expertise on these. So I personally have a preference on one, but I'm also not the one doing the test. And many times patients will live several hours away and have readier access to a different technology that gives us better pictures locally. So I say all that to mean that a lot goes into the decision of which picture we get. A newer technology that is being used is what's called a PET scan, positron emission. And this is a really interesting test where the patient is given, there's a baseline picture taken, and then they're given radioactive sugar. And that sugar is taken up by inflammatory tissues. And a picture is generated from that. And so there's a lot of research being done right now, much of it being done by Peter Grayson, who you'll hear from later. So you can ask him questions about that if there are specific ones. But it's a really interesting technology that can give us additional information. And then ultrasound is very commonly used. It's a little bit of a difficult technology because it's very operator dependent. It's a human with a sensor in their hand looking at the different vessels. And so it is subject to kind of how good that person is. And so really should be done at a place of expertise. The purposes of these imaging, maybe I should have started with that, is we do use these to help make the diagnosis, and what we're looking for are blockages, which we call stenoses. As you become a patient, new patient with vasculitis, you're going to have to learn a whole new language. And that's really what this talk is all about, the CBC, the BNP, the CNP, the LFTs. But if those of you with large vessel vasculitis will need to learn this term, stenosis, and that really just means a narrowing. Aneurysms are also a very important thing we're looking at, particularly in the big vessel in the chest, the aorta. And then some of these technologies can give us some information on, is there inflammation actually in the vessel wall itself? So this is a very complex topic. The rheumatologist will bring some knowledge to it. The radiologist will bring some knowledge to it. And then the radiology tech is a very important part of this to help get really good pictures for the other two to look at. So this is a complex thing. And again, ask some good questions about this and we'll talk about it more. Perhaps the most important thing as a new patient to understand, I encourage you to look over your own images with your provider. As they say, a picture is worth 1,000 words. And I think that it can really highlight and get in your head what's going on in your own body. But this is a patient with granulomatosis with polyangiitis that has some nodules and some bleeding in the lungs. What I wanted to show here, though, is that the orientation is a little bit skewed from what you normally would think. So this is a patient that's lying on their back. The back is down toward the ground. The front of the body is kind of toward the top of the screen. Their head is into the screen and their feet are coming out of the screen. And so there will be different slices, but the mantra to repeat to yourself here is left is right and right is left. So the right side of the screen is actually the left side of the body, and the right side of the screen, left side of the screen, sorry, is the right side of the body. It takes us several months or years to really get used to this as a provider, but when you go over your images with your provider, you'll have a leg up now. These are a couple of examples of a CTA and an MRA, and you can see the level of detail is really impressive. You can see the thickness of the vessel wall. You can see how narrow some of the vessels get. So these are imaging techniques that might be used every 3, 6, 12 months, depending on how your course is doing to check on your large vessel vasculitis. The last thing we'll talk about in terms of specific testing is labs that might be done before you start various immune suppressing drugs. It's very important to have an infectious screen before you start medicine, any types really. Anytime I'm meeting a patient, I make sure these are done. Hepatitis B, hepatitis C, tuberculosis, and HIV. Of course, these are fairly uncommon. I mean, some are more common than others, but these are very important to know the status of as we get into treating people with immunosuppressants. Specifically, those of you being treated with rituximab, very important that the whole hepatitis B panel is done. There are certain labs, you might not have active hepatitis B, but sometimes those that were exposed to it in the past need an additional medicine to protect them from it reactivating. So that's a very important test that needs to be done. Tuberculosis as well, and there might be other fungal tests that need to be done. But it's important to know that a skin test, the one that we usually do, those of you that maybe work in the medical field have had a lot of, apologies for the up there, the skin test might not be appropriate if you're on a good dose of steroids, a high dose of steroids. It prevents it from reacting like it should. And so there are 2 blood tests that can be done. Your doctor will have a preference of one over the other. The other test worth mentioning is called TPMT. It's an enzyme that we all produce in varying amounts. And it's a lab that needs to be done, or usually is done before starting azathioprine or Imuran. There are a couple different variations of this. There are some tests that test for the gene. There are some tests that test for the actual function of the enzyme. That's the one I prefer. But one of them probably needs to be done. There are some patients that cannot metabolize or process azathioprine well, and this test helps us identify those patients and prevent the toxicity associated with it. Lastly, we'll talk briefly about how to approach and talk with your provider about your labs. And this comes from some experience, both as a patient and as a physician. So it's really important during your clinic visit that you discuss a plan for follow-up. I mean, that's a big topic in and of itself, but of course you're gonna say, when am I gonna see you again, doc? But you also, if labs are being done, you need to talk to the doc about when can you expect as the patient to hear from your provider. Some of these labs come back very quickly, within several hours or a day or so, but some take a week or two to come back. And so it's just important. It might save you some anxiety and your provider some efficiency to just develop a good plan of when you'll hear back from them. I usually tell my patients that, I look at the labs every day, and if there is something that is urgent, I will get in touch with you as soon as I see the lab. But, I usually wait till all the labs are back before I get back in touch with the patient. The next thing to talk about is the patient portal. These are very common now with the electronic medical record. It's a super powerful and awesome way that patients can see their own results and also communicate with their provider. It's important to know that if you only have a few questions, a question about a lab or two, I think that's a really powerful way to get a quick question in, a quick answer back. But if you have multiple questions, it might be worth scheduling a formal follow-up with that doctor to review those lab results. And really that's going to be good for you and the provider. It's a space in time where you can ask all the questions you want, make sure you fully understand what's going on. So many times I'll bring patients back, particularly right after a diagnosis, as I'm doing the most labs that I do on a patient, to go over those lab results in detail. That's all I have here. I know that there's comments coming in. I haven't looked at them yet, but I'm more than happy to take any kind of questions and kind of direct the discussion towards specific issues. Thank you all for having me.
Yeah, so Dr. Byram, thank you. I mean, as you said, it's almost like you have to learn a new language for sure. And so thank you for this crash course on our new language that we need to learn here. So thank you. We do have a couple of questions that I think might be very timely here. First of all, I'm going to phrase this in more of a general way. It was specific to one of the more specific forms of vasculitis, but I want to frame it more general. Why would an MRI be used instead of an MRA?
Yeah, so the MRA technology uses contrast and times the contrast when it's flowing through the vessels. And so it gives us a really nice picture of the inside of a vessel, and thusly information on it. Is there blockage? Is there an aneurysm? That's when a vessel can kind of balloon out abnormally. An MR itself, an MRI, it doesn't have that information. So it's really just giving us information on the soft tissues, all the organs, yes, the vessels, but the vessels look a little blurrier on those. So, and there's different reasons for different ones. Like if you're having an MRI, like I have a patient with Church-Strauss syndrome, and she's been having some joint pains that have been difficult for us to figure out. And so I ordered MRIs of some of the joints that we're interested in. And that gives us really good detail on that specific joint. I'm not really interested in the vessels around the joint. I'm interested in the tendons and the muscles and the bones. So I think that is one example of why we would pick one test over the other.
Great, thank you. And just one more quick question here. Dr. Byram, you mentioned that there's more radiation with a CT scan. And in general, we should probably avoid radiation as much as possible. But do vasculitis patients need to be more concerned than others when it comes to radiation?
Yeah, it's a really interesting and complex topic itself. We all are exposed to radiation all the time, like in airplanes, and just like background radiation from everything. Don't get nervous about that. It's just part of it. A chest X-ray is a small amount of radiation, and then a CT scan is, again, about 70 times more. I think I do think we probably should worry more about this than we do. And what I'm saying there is that CT scans are very common tests, and a patient with lung involvement of vasculitis can probably expect to have several. And in the first couple of years of diagnosis, there's a lot. I think it's always worth just bringing that up with your doctor. I've had a lot of CTs, or are you anticipating I have a lot of CTs? And if so, I just want to make you, the doctor, aware that I do want to watch my radiation exposure. I think the patients that I worry the most about are patients with Takayasu's arteritis. These typically are younger patients, and we're getting a lot of CT or a lot of images to look at these vessels. And so that is one population in particular that I want to empower the patient, if possible, to enter into that discussion with the provider on maybe using MRA if possible, if the radiologist can do it. Logistics come into play because that will spare them that radiation exposure over and over and over again. Many times though, I mean, you know, the doctors are aware everything has risks and benefits, and doctors are specifically trained in this, rheumatologists and vasculitis specialists in particular, and really there really are no tests that we order that we're not going to do something with. So I think that's a very important question that all patients can take to their providers about any test is, you know, is this an important test? Is this going to change my management? And if the answer is no, it probably doesn't need to be done. Many times the answer will be yes. It adds information here or there about how the care is going to go.
Great, thank you. And I guess one last question here. There are a couple more questions, Dr. Byram, if you wouldn't mind checking them out on the Q&A section. But just for the sake of the audience here, I'm going to rephrase one of the questions because I think it's kind of the million-dollar question when it comes to tests and imagery. Can these labs and imagery be used to determine remission? Yes,
it's a very important part of determining that. You know, I've actually always said the best test that I have as a rheumatologist and vasculitis expert is my history and my physical. So the questions I'm asking, my physical exam, but the next best test are these labs that we're talking about. And it all goes together for us to determine is the patient in remission, but labs are a very important part. I will make one comment. I see a really good question here on like how often some of these labs should be done. That really will be, there's a range of what's acceptable. I will say there are medicines like Cytoxan or cyclophosphamide that they should be done far more often than in some of these other medicines. And so your provider will determine that. I usually, in patients on Cytoxan, will do labs every week or every 2 weeks. In patients that are on azathioprine, Imurin, or methotrexate, or a medicine that we call Cellcept or mycophenolate, that's more of a every month or every 6 or 8 weeks, depending on how the patient's doing. So it varies depending on how the patient's doing and what medicines they're on.
Great. Well, again, thank you, Dr. Byram. That was immensely helpful. So thank you for your presentation. And yeah, absolutely. Thank you so much for joining us.